Welcome everyone to today's webinar. Are we giving falls the respect they deserve? The role of the nervous system and the care pathway. Today's webinar is facilitated by the Loop Fall Prevention Community of Practice. My name is Michelle Dukeman and I am the Knowledge Translation Coordinator for the Fall Prevention Program at Parachute. I'm going to go over a few housekeeping items, but while I do that, we'd love to see who is joining us today. So if you can, please let us know your role, your organization, and location that you're joining us from in the chat box. That'll give us a good sense of who's joining today, and we love to see that. All right, time for housekeeping. During the webinar, if you have questions about the technology, please type them into the chat box. My colleague Marguerite will be monitoring this space for those general inquiries. If you do have questions for our presenters about their presentation, please submit those through the Q&A box. That appears at the bottom of the Zoom window. Questions for our presenters will be answered at the end of the webinar. You'll only be able to view questions that you have asked, not questions posed by other participants. As always, this webinar is being recorded and a link to the recording will be sent to all participants in a few days, along with the link to the presentation slides. Many of you on the line may already be Loop members, but for those who are not, we encourage you to sign up. Loop is the no-cost online communication platform for the Fall Prevention Community of Practice, and it uses this platform to bring together its members from across Canada to problem solve and discuss how to implement evidence-informed and promising practices in fall prevention. And listed here on this slide are just a few of the services Loop provides. And as always, a reminder, I know we'll get questions, the recording link and the presentation slides will be posted on Loop in a few days. I'd like now to introduce our presenters. Judy Gargaro, manager of the Neurotrauma Care Pathways project at UHN Kite Research. Matt Wiest, policy development and implementation lead on the Neurotrauma Care Pathways project at UHN Kite Research, and Dr. Janelle Unger, assistant professor for the School of Physical Therapy at Western University and principal investigator of the Red Neuro Lab at the Gray Center for Mobility and Activity within Parkwood Institute. You can find our presenters' complete bios on Loop if you want to know more. So without further ado, please take it away, Judy, and I'll let you share your slides.
All right, thank you very much, Michelle. We're really happy to be here. Let me just get the screen sharing worked out. All right, and all right, I think that should be good. All right, so I'm going to be speaking with you today about a really large project, and I'm just going to be talking about a small section of it. I want to give a shout out to my partner in crime, Matt Wiest, who's on this call. We decided I would be the talking head, but he would be there to answer questions, and he will help me out by looking at the questions in the chat. Okay, so as part of this total webinar, we hope that you will appreciate how many people sustain a brain and a spinal cord injury from a fall, and a little bit of the understanding of what we can see about the care and services they receive. And we hope you will recognize how ideal care pathways for brain and spinal cord injury can help people get the right care at the right time. And then I'm going to hand it off to Dr. Unger, who's going to give you a little bit of the neural mechanisms behind falls and what can be done to prevent falls. So we all know the Ontario health system. Well, I'm assuming we do, right? We have the Ministry of Health that funds a body, the Ontario Health, that kind of looks after publicly funded care in acute rehab and community care services. And sort of we understand how this works. But there's also this other part of our healthcare system that relates to sort of more insurance benefits. So there's workplace extended healthcare, either what we get from being employed or what we pay for privately, and motor vehicle insurance. And this sort of takes over after people have publicly funded acute or inpatient rehab care. And it's not that everybody gets access to it. It's very much hit and miss, and the systems are definitely not well connected. And this creates problems for patients and also quality of care. So what do we know about the incidence of TBI? And I put in brackets that we know about, because we only know what gets entered into a database, and we know that's not 100%. So if we look at mild traumatic brain injury or concussion, so these are folks who receive a diagnosis but they don't spend any days in hospital. We're not surprised with the big bars at the younger age group, but I just want to draw your attention to the bars at the far right. And this is also a group that's a little bit more prone to falling. Also, if you look over here, the complex mild group, so these are the folks who spend 1 to 3 days in hospital, and you can see those nice big bars over there on the 65 to 80 plus age group. I lost my mouse for a minute. Okay, and if we look at moderate to severe, we have a similar pattern. So this is incidence per 100,000, all three graphs, and these folks are the people who are more than 3 days in hospital. All right, so that's kind of what we know about TBI, and let's see what we know about SCI. So I'm just using the same descriptors as we did for brain injury, even though they're not commonly used for SCI, but just as a way of comparison. So this first graph are the people who spend 0 up to 3 days in hospital. So it's the combination of the first two brain injury graphs. And you can see we have a bit of a ski jump going, like we've seen on the TBI graphs with a lot of folks over 65. If we look at the moderate to severe group, so these are the folks who are more than 3 days in hospital. Again, we have pretty steep bars at the 65 plus group. So how do falls kind of fit into this incident picture? So falls represent the most common cause of TBI and traumatic spinal cord injury. And if you stop the average person on the street, they would be shocked at this. They would come up with other answers for concussion and for mild and moderate to severe injuries. So you can see there that falls are really a significant part. And the next most common are motor vehicle collisions, which are what most people would think. And you can see that they're hovering around 10%, and falls are over 60. And so you may say, that's fine, that's TBI. It can't possibly be the same for traumatic spinal cord injury. Well, guess what? It's pretty similar. So it's the same kind of idea where motor vehicle collision is the next in line. Motor vehicle collision percentage is greater than for spinal cord injury, but falls, while they're less than the percentage for traumatic brain injury, they're still the majority, the largest piece of the pie. So what we do know about the way the system operates is that quality of care really varies on a lot of things that it shouldn't vary on. So timing for that initial medical assessment and surgery, getting access to specialized rehab, getting connected to appropriate community services. And then we get into individualized comprehensive care that actually considers you as a person and all of those things that make you, you. And so right now, the quality of care completely varies. And it also depends on where you live and how you got injured. So what our solution to this problem is to really develop evidence-based, standardized yet adaptable care pathways for brain and spinal cord injury, with the idea that we were doing this work in Ontario. But it is applicable and relevant to any province or territory. And in fact, we're partnering with folks in other provinces. And so this pathway would balance between public and third-party funded care and services. And we figured it wasn't just good enough to have develop this pathway, but we really needed to focus on implementation. And it was important to develop a companion set of quality indicators to actually evaluate how the system was doing against this pathway of care. So that's the larger project that we're working on. So in terms of our methodology, we engaged over 200 key partners from across the province. And these are folks with lived experience, clinicians, researchers, healthcare managers, funders. So we've got the insurance companies and WSIB at the table, as well as government representatives. So we put all these key partners together. We took a look in the literature about what the best practices were. We put people together in groups divided up by the Ontario health regions. We took a look at SCI and TBI and then we merged them together at the end. And we wanted people to focus on the gaps, the inequities, what was feasible and sustainable as a care pathway, and to really point towards what the policy recommendation should be. So in addition to working 6 groups that were regionally broken down, we also had some clinical subpopulations. So we specifically looked at aging, because obviously when you look at those incidence numbers, how could we not focus in on aging, mental health and addiction, and also Indigenous health. So, and if you recall from the previous slide, we were working on companion indicators. So we also had working groups looking at what those companion quality indicators should be. And we broke those down, looking at different stages of the continuum of care. So pre-acute, acute, rehab, community. We also made a real point of yanking out all the equity considerations that should be there when we are evaluating the system. And the goals of these working groups were really to develop the technical details for those quality indicators so that we would have a roadmap for here is the pathway, here are the quality indicators, and this is how you can both implement the pathway and the quality indicators. So I've been referencing the ideal care pathway, and you're going to look at this nice little simple version and you're going to go, well, that's not very earth-shattering. And it's not very earth-shattering. It's actually all very logical, but there's a couple of things that are important to note. We have on purpose made the community bar the largest because that's where folks spend most of their time. And we actually, if I wanted to editorialize, put the least amount of money, but never mind. But wanted to highlight the double-headed arrows because we need to allow people to move back and forth. We hope they don't have to go upstream, so to speak, but sometimes even with the best healthcare they need to, and this has to be seamless. We're really highlighting the importance of team-based primary care, and again, those equity considerations, looking at environmental personal factors right from the get-go. We ended up developing 3 related but distinct pathways. So they all have the same fundamental structure. They just differ in terms of the best practices. And the best practices are represented in building blocks that are based on Canadian living clinical practice guidelines, but I should stress they may be developed in Canada, but they reference all the international literature, and all of the guidelines, concussion, mod severe brain injury, and spinal cord injury, get a lot of traction from international groups. So they really are internationally relevant. So we built these building blocks on those living practice guidelines, clinical consensus, and also the personal experiences that folks brought as key partners to the group. We wanted to set this foundation of building blocks, but we also recognize that there needs to be sort of personalization that would depend on geography as well as individual goals and circumstances and those individual nuances that we all have, so that we wanted people to be able to implement this pathway no matter what the circumstances were. It's just the actual specific clinical elements might change, but the foundation would be the same for everybody. So this is an example of what it looks like with the building blocks put down underneath it. I know it's tiny. I know you can't read it. That is okay, but it's just giving you an idea of what it looks like in its expanded form. The equity considerations are that big blocks across the top, and you'll see that we go down with the community being the longest stripe, and that was on purpose. So this is just sort of a more blown up version of it. We just chose to put spinal cord injury, but we could have done concussion or traumatic brain injury. It's very similar. And you get the idea of what the building blocks are. So if we look at, let's look at rehab, for example. There's specialized inpatient rehab and specialized outpatient rehab. It's important that there be a connection between those. You may notice that there's a G and an H sitting on those. So that's calling out the fact that there are some significant system gaps that currently exist within access to specialized inpatient and access to specialized outpatient rehab, and that we're working at eliminating those gaps through the implementation of this pathway. The next box down, health system data transfer, that's a hot button these days, making sure that people don't have to tell their story all the time, or that pieces get lost. And we have in-person virtual assessment and management of symptoms, which you may say that's awfully general. Sure, but there's links within that box that connect directly to the best practice clinical guidelines, which will provide more specific information on what you should be doing. So again, super busy slide, not expecting you to really get too much from this, but this is a little bit of the outputs that we did when we ran our working groups, and we asked them to come up with things that were top priorities for them to work on in their region when it came to implementing the pathways. Just at a high level, a lot of people talked about a priority of injury awareness, recognition and diagnosis, improved access to care, and supports in the community for both the person with the injury and caregivers. So that's a bit of a high level. So I did talk a little bit about the companion data already, but I think, my message when I was preparing these slides, I noticed that the problem that I highlighted at the beginning, this is kind of actually pretty much the same thing, where we don't have a clear understanding of what's happening, and there's a lot of silo and there's poor integration. It's kind of the same as what I mentioned when I was talking about the problem that prompted us to do the pathway. And if we look at the solution, you'll note that the solution is actually very similar to the solution that we had in terms of the pathway, where we're going to be developing an integrated assessment strategy for folks with TBI and SCI that provides data to evaluate the key pathway components and identify quality improvement opportunities, and hopefully address gaps across the care continuum by bringing awareness. So our objectives were to take these indicators and map them onto the pathway and to operationally define them so that would help with implementation. This is kind of a busy slide. The take home here is that it's very similar to what we did with the pathways. We engaged key partners, and lots of them. This is the working group structure. We had lots of meetings. We developed lots of indicators, which we realized it didn't make sense to indicate all at once. So we developed a core set. You'll recognize the colors there mapping onto the pathway. So those are the number of indicators in the core set that map onto the pathway. If you want, this is the whole 67. And so we have that core set, which are the priority to implement. Then we have must-haves, should-haves, and then of course there's always a few nice-to-haves. So from this, we developed the technical specs. So who should be collecting the data? Why should they be collecting it? How are they collecting it? And where is that data being submitted to? So we need to ensure that the data collection is consistent. It's important as much as possible to use common data elements. And there's lots of people working in this space. So we've all been trying to engage with them so that we get really a truly common data set. We are collaborating with public and third-party data providers to see what we can do around data connectivity and sharing. And we are also acknowledging the importance of patient-reported experience measures in all of this. So what data is available now? We have some report cards that are out there, the TBI report cards. You can access them through the braininjuryguidelines.org website, or you can get at it from the KITE site. And there's going to be a soon to released SCI report card. So we have a number of different indicators, and that's a whole talk in and of itself, so I'm not going to go in it. But we do differentiate by cause of injury, and sometimes we have to collapse the categories of cause of injury, but we never have to for falls, because there's always enough people in that falls category that we can look at them separately. So I just want to spend a few minutes actually talking to you a little bit about the report card data for both traumatic brain injury and traumatic spinal cord injury. So if we look at mortality, within the first 30 days of injury, falls are sitting at 12%, which is less than road-related injuries. And we also have an unspecified category. There's lots of missing data in our current system. So, that's not unexpected. If we look at the proportion of alternate level of care days or ALC days in acute care, falls have the second highest. So if someone has an anoxic injury, they're the most at almost 33% of their stay in acute care is designated ALC, and falls are up there at just under 30%. If we look at the proportion receiving inpatient rehabilitation after a fall, the percentages are actually quite low. So for specialized rehab, that's 5%. just about 6%, and for general it's just over 6%. But I should say that the percentages are low in general from any cause, so we're not really exceeding about 14% in total getting access to either specialized or general inpatient rehab. The other thing that people ask us to look at is folks who are discharged from complex continuing care or long-term care from either acute care or rehab. And so falls, people who suffer a fall are the most likely to end up in CCC and long-term care. And for those of you listening, you're going to say, well, of course, they tend to be older. Well, sure, that is an explanation, but even if they're older, is that really where we want folks to end up as a desirable outcome? So, and you can see thankfully, not too many people, the percentages aren't that high of the folks who end up in complex continuing care or long-term care. But still, they are the highest of all the percentages that we collected data on. If we want to look at how well people are being followed up in the community by their family physician, so GP there is general practitioner, best practices suggest that after a concussion that you be followed up within 2 weeks. So that's why that number there is within 2 weeks. And definitely we're hoping people will be followed up within 30 days of being discharged from acute care. So a couple of things to highlight, after a fall, and you've been discharged from acute care, which means you've not got rehab, the lowest percentage of people are followed up by their family physician within 2 weeks. So this is definitely not consistent with best practice. The number gets much better if we include up to 30 days, and this is actually the highest. But I think what's really interesting is that there are 20, I see my decimal is missing there. There are almost 20% of people who have no medical follow-up within the first 30 days. For those folks who've had a fall. So I think that's a number to keep in mind. And then you can see after people have had acute care and rehab, you can see those numbers, and that should be 15.26%. If we look at how quickly they get attached to publicly funded rehab services, so these are services that are provided from home and community care. So we put PT in one bucket and SLP and social worker in another bucket. And that's not because we don't know that they're two different things. They're very much two different things, but we had to combine them together because there was too much data suppression otherwise. So folks who have a road-related injury are faster at getting into the publicly funded rehab services than folks who have a fall. And so this is actually kind of interesting to me because these folks, in theory, have motor vehicle collision insurance. And it's interesting that they are getting faster into publicly funded services than folks who have a fall, who are less likely to have insurance coverage. And then OT, it's similar rate between road related causes of injuries and falls. And to a certain extent, this is probably just because the OT gets in there a little faster because there's more of a safety assessment after injury. So what do we know about spinal cord injury? So the mortality after a fall is 8.5% here. This is less than road-related injury. This isn't particularly surprising. If you look at ALC days, falls again have the second highest, and they're approximately 25%. So similar to the picture that we're seeing for brain injury. If you look at the proportion receiving inpatient rehab after a fall, honestly, let me just get rid of the phone. I never get phone calls except when I'm doing these talks. If you look at the proportion receiving inpatient rehab, so after a fall, specialized rehab, it's about 38%, and this is less than the road-related causes of injury, and general is about 9.5%, and this is greater than road-related injuries. So it seems that after a fall and you sustain a spinal cord injury, there's a greater likelihood you're going to be pushed to general rehab than specialized rehab. And these numbers are also lower than if you look at other causes in terms of the percentage that's getting, but you'll notice it's a lot higher than what is happening on the brain injury side. If you look at those who are discharged to complex continuing care or long-term care, the percentages are higher than what we see in brain injury, and falls again are the most likely reason why the discharge destination would be CCC or long-term care. So again, let's look at what happens in terms of follow-up with a GP within 30 days. So you'll notice the percentages are pretty similar to what we saw in brain injury. And also they're similar to each other, whether someone's being discharged just after acute care or if they have acute and rehab. And the numbers are in the same range for the people who have no medical follow-up. And we did, by no medical follow-up, we're also including medical specialists. So there was GPs that we looked at, but also physiatry and other medical specialists. So again, if we look at the publicly funded PT, OT, SLP, and social work, we end up getting a similar picture with folks with road-related injuries getting faster into the public system than those with falls, and OT again being similar. Takes slightly longer number of days to get hooked up than with a brain injury, but and these are the median number of days. All right, so in terms of conclusions out of all of this, so we've developed living guideline best practices are creating those building blocks of care that have allowed us to develop these adaptable ideal care pathways that can be applied across the province, regardless of cause of injury and regardless of location. And we have a companion set of data indicators that's going to look at adherence of the system to these ideal care pathways, focusing on, oh, there we go. I'm just finishing. Focusing on common data elements and data integration. And also we're developing report cards that can show people how they're doing regionally and also provincially. So the goal in all of this is to improve system navigation, reduce inequity, and measure system performance and provide direction for research and clinical improvement projects. So you may wonder what can be done about all of this at the clinician level. So the pathways are really setting out the foundation at the system level. And it's necessary that we have clinical research that can flesh out the best practices at the level of the building blocks so that clinical interventions can be tailored to the needs of the patient and the client. So you'll remember our diagram. And you will remember that I read you that box under rehab. And so if you were to go to clinical practice guidelines, the concussion guidelines, I'm just picking on them, you have chapter 10 that talks about vestibular dysfunction, and it talks then that they should undergo further balance assessment and treatment by qualified healthcare professionals. If you look at the moderate to severe guidelines in our section M, there's a recommendation there that gait re-education is recommended to improve mobility after traumatic brain injury. So at this point in time, I'm going to stop sharing my screen and I'm going to throw it over to Dr. Unger, who's going to talk on the clinical research side of things.
Great, thank you so much, Judy. So I'm going to take us back a little bit. So we've just heard a lot about how falls are a huge cause of neurotrauma and neurological injuries to either the brain or the spinal cord. And I'm going to talk a little bit about the role the nervous system plays in falls, because a lot of my work actually falls into people that already have the spinal cord injury or brain injury, and then the falls that reoccur after. So because the nervous system is so important, once we have damage there, then we see recurrent falls often. So before I talk about a lot of the mechanisms, I always like to start these talks with just a discussion of the systems framework of postural control. So this was first developed by Faye Horak in 2006 and updated by Catherine Sibley and her team in 2015. And it was in response to the fact that a lot of people were saying that falls were, or postural control balance stability was kind of a reflexive response, and that there was one system, there was a balanced system. And this was saying, no, there's a lot of systems that contribute. So the systems listed are cognitive influences, which is things like attention and dual tasking, sensory integration, which looks at how we weight different sensory information that we're getting from the visual, vestibular, and proprioceptive and sensation type systems. Verticality is our ability to orient our body with respect to gravity. Underlying motor systems really look at the properties of the muscles themselves, so their flexibility and their strength. Functional stability limits is how far we can play within our base of support. So we have a base of support, we can widen it further with a gait aid, and our center of mass can move within that base of support fairly comfortably, but as we get closer to the edge, it becomes harder to recover and bring ourselves back. And so our functional stability limits really highlight how close we can play to the edge of our base of support with our center of mass and still be able to recover. Dynamic stability refers to postural control during transitional movements, such as transfers, walking, or wheeling. Static stability then is looking at sitting and standing in one position without a moving base of support. Anticipatory postural control is when we anticipate a movement and we can use feed forward, and we'll talk about that a lot more in depth coming up. Reactive is when we have to respond to a perturbation. And then under the supervision of Crystal Musselman, myself and others also propose maybe adding something like a subjective report of balance confidence to this systems framework as well. Because when we're looking at this is a lot of things that are more objectively measured by a clinician. However, we know that individuals' reports of their own balance do actually have an impact on their balance, and it's not actually related to their physical ability at all. My PhD work and a lot of the work I do focuses on reactive postural control. So that's where I'll spend a lot of time today, but I just want to acknowledge that that is only one system within this framework. This paper came out just last year about reactive balance responses after mild traumatic brain injury, and I really liked this figure that they presented. So they talk about these classes of postural control. And so there's the maintenance of posture, which we can consider those static positions where the base of support is stationary. Voluntary transitions, where now we have a base of support that's moving, but we've pre-planned and it's an internally generated movement. And then we have these reactive responses. Again, often where I see things that lead to falls. So it's an externally generated perturbation. We have to react in the moment. We can't plan ahead. These are things like slipping on ice, being bumped into, tripping on something, and we can't plan for that movement, and we have to respond after, and we have to respond quickly. So again, just to discuss this difference between internally generated and externally generated perturbations. Internally generated perturbations are typically volitional and again, generated from within our bodies. And every time I do this type of talk, someone always will say, oh, what about like a spasm? Because that's internally generated, but it's not volitional. And absolutely, there are exceptions to this rule. But for the most part, internally generated perturbations are actions that we can predict and we can be proactive about. So we can use feed-forward motor control to minimize the disturbance to our postural stability. This would look like when I'm about to lift one leg to walk up the stairs, or I'm about to lift my arm to grab a glass of water. I activate trunk muscles, I weight shift to the other leg in order to minimize the disturbance to my stability, and I can perform that movement. Externally generated perturbations, where again, I will argue that a lot of these falls occur due to externally generated perturbations. These originate in the environment outside of us. So they have to involve reactive feedback-based postural reactions. And what we really need to use is a lot of sensory information to provide our brains with information about the evolving state of instability. So it is an evolving state, right? If you've ever experienced a fall, which most of us have, it happens quickly. Things are changing and we have to try to respond in that moment, which is very challenging on our nervous systems. So the definition Sibley and her team proposed for reactive balance is that it's the ability to recover stability following a perturbation through corrective movements. And the corrective movements that are kind of classed into different categories include an ankle strategy. So this would be a single joint pendulum movement. This is used when the force of the perturbation is quite small. It's also just used to maintain static position in quiet standing, as we have to activate our dorsiflexors and plantar flexors to kind of keep us stable. Next, we have a hip strategy. This is now a 2-joint pendulum movement. We use this when the force of the perturbation is slightly larger. And interestingly, as individuals age, we also see more use of hip strategies compared to ankle strategies for the same level of force. And lastly, again, where a lot of my work has focused is on a stepping strategy. So this is where the force is so large that the center of mass has been moved outside of the base of support, and now we need to change or widen the base of support in order to maintain it. I say that it's used with the largest amount of force. However, we do see individuals elect to use a stepping strategy, even with smaller forces, because it is very, very effective. And so again, this is where a lot of my work is focused on, is how individuals use these reactive steps in order to maintain postural control. We don't know a ton about reactive balance, but we do know a little bit. And so we know that if there's impaired corrective strategies, that is linked to an increased risk of falls and can cause further instability. And this has been shown in many different populations, including older adults, but also those that have Parkinson's disease, brain injuries, or spinal cord injuries. When I say impaired responses, there's several things I mean. So one would be not taking a step when a step would be necessary to recover. One would be taking a shuffle step or an ineffective step. A multi-step reaction when only a single step is necessary to recover balance. So actually taking too many steps is also considered an impaired response. Or requiring external assistance. So in research, this looks like the use of a safety harness often, or maybe in clinical practice, but it could also be grabbing onto another person, a handrail, a parallel bar, something like that. And the other interesting thing, and this is older research, and I know that this has likely changed a little bit, but I still don't know if it's changed a lot, where we've seen, and this again was a survey of Ontario PTs, that reactive balance strategies were actually the least likely aspect of balance to be assessed. And I'm going to explain to you with the mechanisms about why that is an issue. I do have a couple of videos here, so I hope this will work. Mute that. So these are from the Lancet. These are videos that were taken of CCTV in a long-term care home of older adults. So we have an example here of an internally generated perturbation. So this individual is trying to turn. You can see there's a no step response. The center of mass moves outside of the base of support. The base of support doesn't catch up, and we see a fall occur. The next video that I have is an example of an externally generated perturbation. And so this is an example of a gentleman walking his dog. The dog gets in front of him, kind of gets in his way. This is classic with pets. We see him try to recover, but again, his base of support is too narrow. The steps are ineffective and a fall occurs. And I'm sure we can all think of many examples as well. So this is where I want to get into some of the actual neural mechanisms. So again, while we don't know a lot about reactive balance, we do know that the reaction is initiated early, but it can be modified or aborted while it is occurring. And this to me is very, very interesting. And I'll explain a little bit more in a couple of slides about why that is. The other thing we know is that afferent input, so sensory input coming into the brain, is key for reactive control. So we've seen this in spinal cord injury, where they've compared individuals who have a motor incomplete injury, so that they do have some motor activation below the level of injury, compared to a motor complete injury where they don't have motor activation, compared to intact nervous systems. And they saw similar reactive responses because the sensory feedback going up was intact in all of these cases. And so the sensory feedback was coming into the brain, and despite lacks of connections with the motor outputs, we were still seeing similar responses. We also have seen that there's an increase in multi-step reaction. So remember that that's an impaired response when plantar sensation is attenuated on the foot. So we know that the sensory feedback is super key in order for us to have a successful reactive strategy and prevent the fall. I'll first present a very, very simplified model of reactive balance, and this is called the finite state system. So this is just if and then rule, which basically means if certain factors are satisfied, such as sensory input, the environment, body position, all of these things at the top here, then a certain motor task can be performed. And as the inputs change, the motor response will change as well. And this comes from a set of rules that exist within the cortex. And what we have to do, because we have to respond quickly, is select a rule, a preset rule that exists within the brain, and execute it. We execute it, we get feedback about how well that went, and that goes back into kind of our brain and our system, and we can modify the response as we move on. Like I said, this is a very simplified model and provides some of the groundwork for reactive balance, but it does get more complicated. So if we're thinking about the nervous system, and this is why my work has been in spinal cord injury, and I'm very passionate about this area, is that reactive balance is controlled in both the brain and the spinal cord injury and brainstem. And this is really important for me because that's very different from anticipatory balance, and that really affects the way that we treat. So what we know is that the initial response is generated early, and so it must be generated in the spinal cord or brainstem. However, that supraspinal input from the cortex is needed to kind of excite the system and keep it ready to go, and then refine the response according to contextual factors. And how we know this is based off of EMG studies and electromyography, where if we look at short loop reflexes, these are our purely spinal reflexes, they occur in less than 60 milliseconds. An example of this is a flexor withdrawal reflex when you touch a hot stove. So you touch the hot stove, that input goes to your spinal cord, and immediately a message is sent to activate the flexor muscles, withdraw the hand, and before your brain has even registered that the stove is hot, right? So this is instinctual, it's a protective reflex that we have, and it occurs very, very quickly. So we see that motor response within less than 60 milliseconds. On the far end of things, our volitional movements and responses take over 100 milliseconds. And this is because they have to be chosen and planned in the brain and the motor cortex, and then that information sent down to the muscles for execution. And again, what I find so interesting about postural reactions is that it occurs right in the middle. It's on that 70 to 100 millisecond range. And that's why we believe that they start off as kind of what we say medium latency responses that exist within the spinal cord and brainstem. And then the brain comes into play, and it can help, again, refine the response, take in sensory information, and figure out what to do. And that's where we see the late phase and long latency responses. What's really interesting about contextual factors, and what I'll share before the next video on the next slide, is that our environment will change our reactive balance strategy that we use. So if I am, pushed from behind and there's nothing around me for me to grab onto, you won't see an arm response. You may see a short arm response for counterbalancing weight, but you won't see a reach to grasp response. However, if there's something nearby in the environment, like a handrail or my spouse, then I will actually reach out and grab for that item. So that just the environmental context changes how our body chooses to respond to the perturbation. And what I want to note, and what we'll see on this next video, is that that occurs even if the item is not going to be helpful, right? So even if the item is not going to maintain our stability, if we see an item, we will reach for it. So this video is of a gentleman with a balloon. Balance is actually going really well to the start. So we can see the stepping. We can see here he widens his base of support. He's doing a great job. What happens though, again, base of support becomes too narrow. He catches his foot, and we see that reach out for the Christmas tree, which was not a helpful response, but his body, again, doesn't always choose the best option. It's just taking in the information as quickly as it can and trying to make a decision about what to do. And so all of this is kind of just summarized by saying what we all already probably know is that falls are very complex and they're very multifactorial, and therefore our treatments really need to be multifactorial and complex as well. So if we go back to my first slide with that systems framework of postural control, what I always ask myself as a clinician is, why are falls occurring? When are they occurring? Is it when there's externally generated perturbations or internally generated perturbations? Is it when an individual is dual tasking, right? So what systems are at play here? And I want you to remember, I've talked a lot about reactive balance today. It is only one component. I will always argue that it's a very big component for falls, both before and after a neurological injury. But it is only one component, and we need to consider things like cognitive influences, motor systems, sensory integration, and balance confidence as well. Also consider those classes of postural control, right? Static, dynamic, anticipatory movements are all really important. And this is where I say that you can't train reactive balance the same way you train anticipatory. And what I see a lot in clinical practice for balance training is a lot of anticipatory movements, right? Standing on one leg, standing on a foam pad. These are things that individuals can anticipate, use feed forward control, and minimize the disturbances. But what I truly believe we need to do is add in external unexpected perturbations in order to train that reactive system, because it does live within a different area of the nervous system. And so there's not as much transfer between those two as we would like. And the last thing I'll say about the mechanisms here is that personalization is really key. And so we heard a lot about the bigger system, but then what Judy left us with is that at the clinician level, we really need to think about our clients on an individual level. And so now I'm just going to present very briefly some of the work we've been doing at the Gray Center for Mobility and Activity, which has recently been established at the Parkwood Institute in London, Ontario. So I won't go too much into this, but Gray is really looking to integrate research, clinical care, and education, and our focus is on mobility and activity for anyone with mobility impairments. So the populations we serve include geriatrics, individuals that have had amputations, individuals post-stroke, post-spinal cord injury, post-traumatic brain injury, and even mild traumatic brain injury as well. And so we're looking at all of these individuals. And for me as a researcher and a clinician, the thing that everyone has in common is typically falls. And so we want to use very innovative and collaborative co-design approaches to solve the challenges that we're seeing and develop novel and accessible programming for patients and community members. And while we're doing this, we're really trying to ensure that we focus on the whole person. So some of the core activities that have already started are looking at research project productivity and impact. Getting the knowledge into clinical practice is really important for us. And then again, co-creating treatment strategies and assessments. So I'll talk about a couple of the things that are going on right now, and then that will be the end and we'll wrap up for questions. So the first thing we have occurring is a virtual fitness center. This started during the pandemic, no surprise. It's offered through Microsoft Teams, and we have various fitness classes that I've listed here that are led by instructors with lived experiences of disability and mobility impairments. Here's a screenshot of some of our student volunteers with this project. They often act as spotters during these classes. Since they're virtual, the spotting is having a list of emergency contacts and reaching out if we have any concerns about any participant in the class. They also can show, modifications of different exercises and things like that as well. This work is being led by Dr. Dalton Wolf and the research to practice team at Parkwood. And I know that there's talks about, now that we're back on site and we can open up a bit more, that perhaps we could have a hybrid option, because people actually really do like the remote options as well, because we can reach a wider audience. Something else we're really looking at is interdisciplinary experiential learning and getting different professions together. So we're exploring our options to pair trainees from different schools, so medicine, PT, OT, SLP, pharmacy, nursing, and we're looking at when they're at Parkwood on placements, what kind of education sessions do they attend, and can they attend with each other or go to each other's to learn more? Can they pair up for treatment sessions where we have a med student come to a physio session and then the physio student go attend the clinic with the med student? We're currently collecting data on enablers and barriers to this model, and looking at the possibility of a student-run clinic that would help reduce wait times, increase placement opportunities, and optimize clinician resources. And we're hoping that we'll have this information out soon so that our work can provide the foundation for other sites that may be interested in this as well. And I'm happy to chat more about that too. And the last piece I want to mention is this personalized mobility programming. So this is a really cool project that we have ongoing right now that was funded through a New Frontiers in Research Fund. And the goal of this is that we're trying to develop an approach for personalization of mobility programming for a diverse group of people with mobility impairments. And again, this sounds like what we already do, but we're really we're guiding this by the preferences and values of people's lived experiences. It will be informed by patient-reported outcome measures and behavior change theories, and it's developed using co-design. And the cool thing about it is that we're using algorithms based off assessments to determine different pathways of care for people, and determine what might the best treatment options be. The treatment options will include things from physical activity standpoint, such as exercise classes, counseling, such as cognitive behavioral therapy in order to maybe increase motivation, and then wellness programming, such as education sessions or peer support programs. I have a flow diagram of how this might look. So when a patient is referred, they'd be screened for appropriateness. And as a researcher, what I love about this is that we've included research in this model so that if there are any relevant research studies ongoing, we can get those people enrolled in trials right away. However, they all would then receive an assessment specific to them. And then with that assessment, looking at best evidence, our mobility experts and patient preference, we can tailor treatment recommendations to that individual. And again, we're using an adaptive design for this, which please don't ask me too many questions about. We have a computer scientist and epidemiologist working on that aspect, and it's things far beyond my knowledge with computer science. But we would then put people into different types of programming, maybe group programming or one-on-one, looking if there's any medical interventions that might be necessary or any other treatment strategies, moving people to reassessment, using the data to then reinform. So again, I know this looks like a lot what we already do, but this is a way that we're trying to kind of standardize the individualized aspect of rehab. And I'll just bring us back to the last slide that we saw from Judy, just reminding you that the pathways that they've mentioned are very important because that's at the system level. And a lot of the work that I've presented today is looking at how we can flesh out those best practices at the level of the building blocks so that our clinical interventions are individualized and tailored to the needs of our patients. That's all that we have today. I have the slide here with some of our contact information, and I think now we're happy to take any questions.
Fantastic. Thank you so much, Janelle and Judy and Matt. That was a great presentation. I love the systematic look and then the clinical applicability. So we love to see that. Thank you so much. We do have a couple people who have put questions in the chat or Q&A box. Just a reminder, if you've put a question in the chat box for our presenters, please put it in the Q&A. The Q&A is at the bottom of the Zoom screen. There's a button there where you can put it there. That makes sure that it gets answered. So I'm going to do a few other housekeeping items before we turn over to those questions. So you've got time to put those questions in the Q&A box. First of all, when the webinar has ended, you will be redirected to Zoom and invited to participate in a short evaluation survey. You'll just click the continue button on your browser and you'll be redirected there. So thank you in advance for filling that out. It really helps us continue to put on good quality webinars like today's. So thanks again in advance for that participation there. Now I think we can move over to the questions. The first question we have is the outcome measures for balance that I am aware of only measure anticipatory reactions. Are there any outcomes for external perturbations?
Yeah, I can grab that. So that's definitely a challenge that I've had in clinical practice myself. One that I like to use is the mini best test. It does have a whole section for reactions where you have a patient lean into your hands, remove the support, and see how many steps they need to recover. So obviously from a clinician perspective, we have to think about how we can do that safely for both ourselves and our patients. But that's a really good one that I've used. It was developed for research, but we've been trying to get it more into clinical practice recently. But you're absolutely right. A lot of the measures that we have don't have a component for reactive balance. And I think part of that is the challenges that are associated with measuring reactive balance. But I will always be here to argue that it's so important that we need to find ways to do it safely.
Awesome. Thank you. All right, the next question, I think likely for you again, Janelle. It says, Janelle mentioned something about external perturbations being needed to promote that learning. How does that happen safely? Is there an obstacle course or something like that that's being used?
Yeah, so again, another great question. And I think we do always have to think about safety. And so the work that I used was just using manual perturbations, which is a nice way of saying pushing and pulling people. While they were doing other challenging balance tasks. So providing that they're already in a challenging balance situation, and now we provide an external perturbation that's unexpected. We did always have people within a safety harness, not providing any body weight support, but that would be there to catch them if there was a fall. And that was just implemented within a clinical space. I have seen people using the walking harnesses with a ceiling track and things like that as well. Having a spotter, this is not something that we're doing on day one with anybody. We like to get to know our patients first and kind of understand their abilities before we really challenge them in this way. But I do think that, again, it's so important. We need to find ways to safely implement it. And we do need to learn through error. So people will experience errors, right? They will, quote unquote, fall. Again, if they're safe, they won't fall onto the ground. They'll need support from the harness or another person, but they need to experience errors in order to learn. The same way that we see in childhood development and things like that. And so I really encourage people to be creative in the ways that we can do this type of training in a safe way.
Great, thanks, Janelle. The next question, what are the upcoming directions of this program, and are there any continuous improvement initiatives? I think I'll let you each speak to if you have answers for each of your respective programs / pathways.
So on the work that we've been doing on the Neurotrauma Care Pathways project, we're in the third year of our funding. So this year we're going to actually be working some pilot projects on implementing things that are addressing those key priorities that I presented, and we are really collaborating, I have to say, with WSIB and even with the motor vehicle insurance companies around data collection so that we can get a better sense of what we're doing. So we're sort of implementing pilot things and still learning. Our long-term plan is to hope that Ontario Health would recognize the need to have ongoing support for these kind of quality initiatives, similar to what they do with stroke and with cancer in terms of pathways of care and those report cards. So that's ultimately where we're going. So we're in communication with them, because it's 160,000 people with concussion every year in Ontario, 5,000 people with traumatic brain injury, about 500 people with traumatic spinal cord injury in Ontario. So it's not a tiny number of patients. So we're really hoping that that's kind of our long-term plan. And by building the pathway and data the way we have, we're hoping that people can also take it on and do their own local QI projects and engage in constant quality improvement. Matt, I don't know if there was anything else that you wanted to add to that. Okay.
Yeah, and from the Gray Center perspective, so the Gray Center is fairly new. It was actually established during COVID, so I'm sure you can imagine the challenges that come with that, and that we're now kind of able to really open up the research and get back to things kind of pre-COVID ways. So we're still new. We're still in a lot of the development phases, piloting phases, not unsimilar to the work that Judy and Matt are doing, and really looking at how we can make sure these things are sustainable in the long term. And so piloting a lot of that, trying to do the groundwork now to make sure that once we have good programs in place, that they can be maintained.
Great. Thank you both, Judy, Jill, and Matt. That is all the questions that we have, and we're running right on time, which is always good to see. I'll remind everyone to fill out the evaluation survey, please, that pops up after this. I will be in touch in the next day or two with a link to the recording, a link to where you'll be able to find our presenters' slides. I'll share, thanks Matt for sharing the Neurotrauma Pathway Twitter. I can share that in the follow-up email as well, and I'll also provide all of our presenters' contact information if you need that as well. So finally, thank you again, Judy and Janelle and Matt, for a fantastic presentation. Also to the other contributors I see on the slide right now, thank you to them for all of their work on this. And I want to thank everyone who joined us today. It was great to have you, and we look forward to seeing you at upcoming Loop webinars.
Thanks, everybody.
Thanks all. Have a great rest of the day.